time, and you can start.
Good morning, everyone. Thank you for joining me this morning. I'm just going to take us through some troubleshooting tips for treatment of voice and swallowing problems of TL. We have had very many of these in the last while. So these are just some of the things that we do as speech therapists, and I'll also talk through where we refer to you and what are some of the options that we will discuss with you in managing these patients. So when we think about so I have to move the mouse, sorry. There we go. Sorry. So when we think about voice problems, they're generally one of two causes in patients with a total laryngectomy. It's either an anatomical reason or there's a prosthetic reason for the problem. Very easy rule of thumb, when there's a voice problem, again, you obviously want to check to make sure that the voice prosthesis is looking intact. That there's no obvious mucus plug, it's clean, the patient has done everything that we've told them to do in terms of cleaning and looking after that prosthesis. If there is still a problem with the voicing, you then want to remove the prosthesis and trial open track voicing. That then gives you a clue as to what the problem could potentially be. If you notice there's some fluent voice, once you remove that prosthesis, it's generally then a prosthetic problem. If the voice is strained, epithelial, or there's no voice, it's an anatomical problem. With the problems with the prosthesis, so some of the issues that we notice and that we see, and you guys send patients to us, is the leakage through the prosthesis, and it's the most common reason for why we replace the prosthesis. And the causes of the leakage through the prosthesis is candida, and the candida is what grows on the flap valve, and that then results in poor closure of that flap, and then there's leakage through of liquids. The flap can also become stuck in the open position with mucus, with debris, and in those cases, it's potentially because of poor cleaning and hygiene. So that's something that we would then look at. There is also increased negative pressure that can occur within the esophagus, and that may result in the prosthesis flap opening up spontaneously, and then there's leaking through that prosthesis. So how we would treat it, so if there's candida on the flap, we'd ideally want to replace that prosthesis. If we notice any mucus, you want to flush that prosthesis, try and clear it out, or you want to brush the prosthesis. If it's a hard mucus plug, we sometimes have to remove that plug with forceps. So sometimes we add a bit of water to soften up the mucus, but you may need to use a tiny forceps to just actually pull out the plug. And if it's because of the increased pressure, what you then want to do is change that prosthesis out to one that has an increased resistance. With the candida on the prosthesis, so that's what it looks like. So tiny little deposits that grow into the silicone of the prosthesis. And it's generally Candida albicans. If we find that treatment isn't working, what the companies suggest to us is that we actually send away the prosthesis for further testing in the lab. Here we don't routinely do that just because it will add quite a bit of cost to try to find out what the specific organism is. Candida can cause the leak, so we want to do a leak test when patients come to us. We give them a bit of water to drink, and we will then notice through the center of that prosthesis. So through that flap over there, you'll notice the leak. What the patient may report to you is that they're struggling with voicing. So you may not initially see the candida on the tracheal edge of the prosthesis, but the patient then reports a bit of strain with trying to voice. It's a bit more effortful for them to get their voice out. And then it may be that it's candida on the other side. What we do see is that it's more prevalent in patients who are immunocompromised, patients who have diabetes, patients who have poor diet as well, patients who have regular therapy, they also tend to have more candida. And then our malnourished patients. Diet is a big thing that we also counsel our patients on. We have many patients who prior to TL are quite heavy drinkers, and beer is the culprit. with the yeast and that's in the beer, and that then just increases the growth of the candida. With our prosthesis device life, an average device life is roughly 3 to 4 months. There are patients who have prosthesis device life that's longer. And then there are device lives that are shorter. So you want to look at in your patient where that device life is short, is it potentially the candida that's causing the problem? So where we see a patient coming back to us within a few weeks of placement of that prosthesis, candida is one of the things that we look at. Again, the device life is variable between patients and within patients as well. So things change as we work with the patient. Candida can usually be seen with the naked eye, so once you remove it, you can usually see the deposits on the prosthesis. So what we do to treat it, so yes, the first prize, replace the prosthesis if it's coated in candida. We do often refer to the ENTs just to write up a prescription for the antifungal treatment, so the bariatriconazole with the nystatin gels. And what the patient has to do with that is to put the nystatin gel on the brush tip and insert that gel into the prosthesis so that the gel gets into the area where the candida will build up. We can change out the prosthesis to a non-indwelling prosthesis. So we get indwelling and non-indwelling. The picture over here, that's an indwelling prosthesis. This one here is a non-indwelling. With a non-indwelling prosthesis, that one just allows the patient to take it out and clean it more frequently. And what we suggest they clean it with is the hydrogen peroxide solution, which then just eats off all the biofilm that grows on the prosthesis and can aid in just device life. In patients who do this, we often issue them with 2 non-indwelling prostheses so that they can then change out their prosthesis. So while the one's been cleaned, they then place another one for use to speak and to eat safely. The other reason or the other solution that we have is to place an extended wear prosthesis, and that's a little prosthesis that has a magnet, or it's got the silver oxide within the prosthesis flap, and that then prevents or reduces the chances of the candida from building up. And how you know the difference with the prosthesis, you'll see that little silver thing with the mouse. And that's the little magnet that then helps. In the Blomsinger range, if you don't get, you see a little silver coating of the silver oxide on the flap. And then we do counsel them just around dietary recommendations, so eating more yogurts, because that helps just with keeping your gut healthy. Probiotics, garlic. We have some patients who use aloe, and they've reported that that's helped. So they put the aloe gel into the prosthesis. Again, we haven't tested the aloe, so we don't know in terms of efficacy, is that something that's as effective as the other recommendations. Then another problem that we have is leakage around the prosthesis. So this is where it's caused by a prosthesis that's too long. So the prosthesis then is moving and pistoning within that trough. And with that movement, it ends up eroding the top of it, and it causes that trough to widen. There can also be atrophy that can lead to the enlargement of the top. And the causes of atrophy, this is where we need to investigate why is this happening. So it can be as a result of radiation treatment. We know radiation has very many side effects. Chemotherapy is another cause of atrophy. There can be recurrent, so again, we will refer to the ENTs just to investigate to see what is going on, what's causing the atrophy. Poor nutrition. So for the poor nutrition, we need to refer to our colleagues in dietetics just to manage that optimally. There could be poor thyroid functioning, there could be uncontrolled diabetes. And again, there we need to look at just the medical management of that, and is that optimum? Puncture creation, that can also just result in top expanding. And then reflux is the other issue that comes up in very many patients. And we often refer patients for a PPI for treatment of the reflux. So some of the things that we do when we notice that the prosthesis is oversized, we will resize that prosthesis and then replace it with one that's got a snug fit. So where the flange fits quite comfortably on the tracheal side, tracheal wall. And the esophageal flange is what then acts as the seal. So if you've got a quite tight fit, it helps prevent that leakage around. Again, like I said, the investigation just to kind of find out what's causing the reason for the breakdown in that trough or that atrophy that's happening. In terms of your surgical procedures, and here you know more than what I do, so the purse string suture is one of the ways in which you can assist with closing the trough. Augmentation, we haven't done too many augmentations where we inject a substance into to bulk up the tissue around it. We've done it in one patient where it's helped, and then it is a repeat augmentation that's required just to keep the tissues quite snugly around the prosthesis. But we don't have very many of those cases. We may need to surgically close that top and then repuncture, or in some patients, and what we do here more frequently, we remove the top and wait to see does that top then nose on its own. Again, if the patient is nutritionally compromised or if there's some other underlying cause, it may not. And then we can also use a prosthesis with an enlarged flange. And that just helps create that suction effect where it's quite a tight fit and helps prevent the leakage around. Where you notice your patient has strained, effortful voice or no voice. So the causes of that is either forceful stoma occlusion and or physical tension due to anxiety, and that then results in increased segment tonicity. And this is your patient where you notice they're pushing quite hard or they're sitting there quite tense, shoulders up, and entire body is just tense, and they will then struggle with voicing. If we notice that the prosthesis is too long, so when they occlude, it then pushes against the esophageal wall, so airflow doesn't go through. There could be increased resistance within the prosthesis, and the patient that the airflow then isn't able to get through that prosthesis to vibrate the PE segment, or the prosthesis might be blocked by mucus, food, or debris. So obviously, you check your prosthesis first to make sure it's clean. If you need to flush, they need to brush, or if there's a plug, it needs to be removed. If there's an increased resistance with that flap, so the indwelling prosthesis have a bit more resistance than the non-indwelling resistance, and it's again just dependent on the silicone material that it's made of. So your non-indwelling is a softer silicone, which has a slightly lower resistance. So it's easier for the airflow to go through. So we'll change it out to that one. If we're noticing it's the size of the prosthesis that's incorrect, where it's pistoning, it's long, it's sitting in that tracheal area, we want to then resize and change down to a smaller prosthesis. And then for our patients that have quite a bit of tension, again, there we need to work with them on relaxation. So teaching them just to relax all of their muscles in the neck, in the chest, shoulders, because if they're all tense, we need good airflow to be able to speak comfortably. So we take them through some relaxation to just help with easier airflow, and then gentle occlusion of the stoma so that there's a bit of reduced tension. And some patients struggle quite a bit, and it takes quite a while to get them to that point where they can relax. Other causes of a strained effortful voice or no voice. So there could be problems with the PE segment, the tonicity of it. So there could be hypertonicity, there could be a stricture, or there could be spasm. And that then just results in poor mucosal vibration and concomitant dysphagia. So you want to ask your patient about, is there a swallowing problem with the voicing problem? Because that just helps you think through what is causing this problem. There could be hypertrophy of the tissue around the puncture. There could be swelling or thickening of the tissue due to irritation by a foreign body. So the prosthesis in some patients is just causing quite a bit of irritation. And what I found in one patient, it led to the device just malfunctioning completely, and she had voicing problems and swallowing problems within a month. And we had to replace a prosthesis every month. And we treated the reflux, we treated the candida, but the device health was still short. And I think for her, it was just the irritation of having a foreign body. So the inflammation, it causes a raised reddish area. So what you see here in this picture is a little bit of that donut effect. And here, the granulation tissue that's formed has actually pushed that prosthesis out. In this picture over here, you can see there's granulation tissue forming. So there's that pinkish rim just underneath the flange of the prosthesis. And here, the prosthesis is embedded into the tissue. So for all of these problems, if there's hypertonicity, we would then refer for either Botox, or if that doesn't work, further surgery, so cricopharyngeal martomy, or sometimes dilatation. If it is because of an irritation, because of bacteria that's growing, obviously to treat that. Removal of the granulation tissue is then something we often refer to you for. We either use cautery or laser to remove the granulation tissue. If it's a problem just with the size, and the size of the prosthesis is the main contributing factor, we then need to resize and place a longer prosthesis. So if it's quite a tight prosthesis, it then embeds into that tissue, causes irritation, and using it, the excessive granulation growth. So in this case here, where the prosthesis has extruded because of the granulation tissue, we then remove that, allow that top to completely close, and then need to repuncture. Sometimes there's a pinhole top that's left. Sometimes we can dilate that, sometimes not. And again, it depends on the patient's tissue, how flexible it is, elastic it is, for us to actually dilate up. If not, we rather let it close and then repuncture and create a new top. Microstoma, and again, we've seen quite a few patients with this. And it's a small stoma that then compromises the airway. And it's usually from stenosis, generally after radiation treatment. We have had some that haven't had, but have also still had a bit of stenosis. We do recommend dilatation of that, and again, at least a size 8 or size 9 tracheostomy or Larry tube, because that allows us to fit size, replace the prosthesis. If it's smaller than that, it is too small for us to work through. We do issue patients with fenestrated Larry tubes, and that they can wear and during the day and at night, and they can still speak with the fenestrated tube. In cases where we don't have stock of the nice soft Larry tubes, we do then issue them with a tracheostomy tube, and again, it's just for the patency of that stoma. They may need surgical revision of the stoma if it's really tiny, and that's where because we'll do a stomoplasty. And again, our preferred size is about 2 centimeters. Smallest is about 1.5, which equates to your Larry tube of a size 8 or tracheostomy tube of size 8. The macrostoma, so this is where there's just a really large stoma. And this is a problem for voicing because it makes it difficult for the patient to digitally occlude that stoma so that they can get a good seal and the airflow can go through the prosthesis. Some patients just have a naturally large stoma in an area, or there could be tissue breakdown. Where there's tissue breakdown, again, we need to investigate and see what is the cause of that breakdown. And and then treat either of those causes. For the big stoma, we can issue them with a Larry tube, because that just helps create a smaller space through which to occlude. We sometimes need to issue them with adhesive housing or a cassette that then sits in that stoma, and that then also creates a smaller space that's easier to occlude. There is the hands-free valve that also sits on a casing. That is then an adhesive that has an opening that's then smaller than their stoma. We don't issue those here just because they're quite expensive and our budget doesn't allow us to do that for our patients, but they are available should your patients need it. And then what we've done for some patients is just create an adaptive stopper. And what we end up doing is taking the glove, popping it with cotton wool, creating a little ball that then is big enough to occlude the stoma, and they then use that to occlude, because if their fingers don't fit, they need something to occlude. So that's one of the things that we've done and seems to work quite well. Poorly placed fistula. So yeah, ideally we want the tuft to be about 5 millimeters below that upper edge. If it's too high, like in this picture over here, it results in that front port of the voice prosthesis kind of sitting out, and when the patient tries to occlude, they actually occlude the prosthesis and they can't get airflow through that prosthesis. If it is too low and recessed, it's then also quite difficult for us to work through. But then they can also, the prosthesis can also just get blocked, the front of it gets blocked and airflow doesn't go through. So some of the causes, poor attention to surgical detail. So again, yeah, take note when you are creating those tufts so that we don't have ones that are quite high up. And then the other cause is the dragging effect of a Foley's catheter. So where we weren't doing primary placements, primary function, primary placement, and using the kit, we were placing Foley's catheters after the TOF was made. And that TOF with the bulb, the Foley's catheter with the bulb inflated, just has that dragging effect where it then pulls down the TOF. And if it's low, it's just very difficult for us to work through. So in this specific case with this gentleman, what we actually did was we changed to prosthesis with a narrower diameter, so the flange was slightly smaller, and he could then still use the TOF and sleep comfortably. But where that doesn't help, we do need to then get that TOF close and repuncture. You can also look at valve housing, but we don't really do that here. Then some of the swallowing problems that happen is the aerophagia. So where your patient just complains of gastric bloating, discomfort, flatulence. We do counsel patients and say that this is sometimes a side effect of the surgery. And it's because of the negative pressure. So when you're trying to speak, airflow goes through that prosthesis, but some of it travels down into the stomach. So for most patients, there is a little bit of the bloating, there is a little bit of flatulence, and we do counsel them around that so that they are comfortable with it. They need to inform their families. And we also counsel them just on the behavioral appropriateness of what you do in those cases, because it can become quite an embarrassing and uncomfortable thing for them. So we do counsel around that, but then we also look at, is it the prosthesis that's causing that increased airflow into the stomach? Do we need to change out the prosthesis to something that has an increased resistance so that there's less airflow down into the stomach? Yeah, so we also just look at keeping patients are with food so that they're not using quite as tense production. Because again, with increased tension, you just end up getting more air down into the stomach rather than up through the valve. We sometimes need to evaluate that segment tonicity, just to see how well it is vibrating, how well it is moving. And if we notice that that is the problem, we may then recommend Botox or anatomy for that. We don't have too many patients that have a big problem with aerophagia, but it is something that does occur. And generally, with the behavioral management and the counseling, they are able to manage with it. The other swallowing problems, the aspiration, is a big concern for us because we don't want our patients to land up with chest infections, pneumonias, needing to be admitted for treatment of that. So the cause of the aspiration is leakage through the prosthesis or leakage around, or an extruded prosthesis. So we have had patients come to us and they can't swallow, they're coughing. We look at them and the prosthesis is out and they haven't noticed. So that does happen. So you want to, and what we do standardly is we issue our patients with a Foley's catheter, so that should the prosthesis extrude, they can use that to just stent the hole, keep it open, but then also prevent some of that aspiration from happening. When there's leakage through or leakage around, they need to come to us as soon as they can. And then we look at either replacing the prosthesis. So if it's leakage through, it means that flap is not working, we need a replacement. Again, with our stock issues that we have in our budget cuts, it impacts on availability of prosthesis. So what we sometimes issue patients with is this plug, and the plug then fits into the entrance of the prosthesis, and it occludes it, so they place the plug for when they want to eat and drink, and they can eat and drink, and when they want to talk, they remove the plug, and they can talk comfortably. So that just allows us to keep that prosthesis in for a little bit longer until we get stock. So it is a temporary solution. The ideal is to obviously replace the prosthesis with one that fits better. For leakage around, we also do place the prosthesis that has an extra flange. And the extra flange sits on the esophageal edge, and it's, as you can see, wider than the esophageal flange. And that just helps create a better seal, tighter seal, then results in less leakage or no leakage. The esophageal dysphagia, so this is also a common problem that we have, and the causes are radiotherapy that then results in stricture. And how that's managed, so the strictures we then refer for dilatation, and often patients need repeat dilatations because the dilatations aren't effective, or they only give the patient a little bit of relief. And this is where your patient will complain they can't get anything down. And we usually tell our patients to let us know when it is that they're not coping, not managing. How we manage this is just with changing the consistency of what they eat. So if they're struggling with solids, we then tell them to have softer, smoother food, semi-solids. If they're struggling with that, they then move down to liquids. It's not the best diet to be on, but that is then how they eat. It may get to a point where it is that severe that very little is going down, and then nutrition is then compromised, and in those cases we then refer for peg placement so that they can have their nutrition. Some of the investigations we do just to check out that stricture is the barium swallow or modified barium swallow. Again, either or will identify the stricture. The modified barium swallow just allows us to objectively see, in terms of the consistency, what's the easiest ways of holding up. So we'll then do a graded approach to the consistencies that we give them in that study. And it just allows you to counsel them and advise them on what's easier, more comfortable for them to eat, and the types of food that they should then stick to. Radiotherapy is one of the things that causes lots of problems down the line. So while the patients are getting treatment for radiotherapy, they might not be voicing, or they might struggle with voicing. And again, that's because the tissue is quite tender, occluding is sore, it's painful, it's uncomfortable. And And in those cases, we then don't encourage them to speak because it's just causing too much discomfort. The later effects of the radiotherapy may influence the voice quality. So as time goes on, you may have your patient come to you and say their voice is now difficult, they're straining, it's more of an effort to the voice. And if you sorted out the prosthesis issue and you sorted out, and you know that it's not a spasm, it's most likely the radiotherapy that has then resulted in stenosis and fibrosis of the tissue, so there's less vibration that happens. And in those cases, the patient will eventually lose their voice because they won't be able to get a vibration. So it is something we need to counsel them on when you notice that starting. Again, how long that takes, how short that takes is patient dependent and very variable. So it's about informing the patient so that they're aware and then looking at alternative means of communication when that does happen. For patients who have been speaking for quite a while and are using quite good articulation, over-articulation can be quite a good way to get around not having the voice so that you can still be understood. And then, the alternative communication, so looking at communication boards or communication devices, text-to-speech devices, technology, quite a few options there, but again, it's looking at what does the patient have, what resources do they have, what are they comfortable using, because it doesn't help to give them something that doesn't actually work for them or their family. The side effects of radiotherapy, so we counsel them extensively on this, and we do need to re-counsel at a later point, because patients will forget that right at the beginning they were told all of these things, so if they come to us 5 years down the line, 10 years down the line, 15 years down the line, it may be the impact of radiotherapy that we only seeing then. So we have to counsel them just around these things. Some of the things they struggle with is the mucositis, the skin erythema, the xerostomia, the loss of taste or appetite, lymphedema, or there's the other fibrosis, stricture and dysphagia. Lymphedema, we can refer to our colleagues in occupational therapy, we can just assist with managing that. Loss of taste and appetite, very difficult sometimes manage, but we get our colleagues in dietetics involved as well, so that at least when the patient is eating, they're eating the most nutritious meal that they can that's got high calories. With xerostomia, some of the things that we recommend there is just that they carry some water around with them and they're able to take a sip. Ice chips, just if they're in the ward and they've got quite a dry mouth, it just helps with the hydration. The redness and the tenderness is something you just have to be aware of. If there's any oral pain, you obviously treat oral pain and the ulcers that then arise with whatever medical treatment is indicated. Some of the other problems that we see, so if there's excessive mucus or discharge, and it's often a cause of emphysema, and it's due to a lack of heat-moisture exchange. So there are heat-moisture exchange devices that you can house on a Larry tube. Those are quite costly, but we don't do them and they need to be replaced daily. What we do issue our patients with are the stoma covers, so the cloth covers that they tie around their neck. And what we advise them is, if they're struggling quite a bit, is that they can wet the stoma cover, squeeze out the water so they have it damp, and place it around their neck, and that then just helps with the humidification. In patients where they've got a hypertonic voice, so these are usually our patients who had a gastric pull-up as well, and they end up with quite a weak, soft voice. So there we look at just compression of that PE segment and getting them to wear a band that then helps. If you notice a wet voice, and that's usually because of accumulation in the throat, so it's the saliva, liquids that they've had to eat, drink, or food that they've had to eat, you want them to clear that. So we get them to do a forceful voicing, so to just clear it out. So occlude, clear it out to expectorate, or to just swallow hard and wait for the fluid, the liquid, to actually pass the prosthesis. Otherwise, it just sits there and you have the same problem. And in patients who just had their surgery done, that's something that comes up quite frequently. So right in the beginning stages, we train them just on waiting a bit before they start speaking after swallowing. Gagging is also something that patients report on. And it's often right in the beginning stages where they're starting to voice, they may gag, and it's just that they're not used to that feeling of airflow up through the tract. Or it can be because there's mucus that's sitting there, and when you've had the postnasal drip, that kind of feeling of that thick mucus that you just can't get rid of. So if it's thick mucus, again, hydration is important there. You want to look at just thinning out the mucus, but also getting the mucus out, so coughing it out. And then desensitization with speaking, so lots and lots of practice just in that initial stage so that they can get used to it. With that desensitization, it's also sometimes just getting them to push through the voice production and not stop when they gag. Because if they stop, they don't get desensitized to the feeling. So that's at the end. So just in summary, the surgical prosthetic voice restoration, it's the method of choice of fluent voice, and it's what we do here mostly. The tonicity of that PE segment is crucial for success of voicing. Hypertonicity, spasm, or the PE musculature is the most common reason for failure to achieve fluent voice. And often that happens quite early on after the surgery. And we pick that up. If it's later on, we need to then look at what are the other causes. For optimal results, there needs to be attention to detail when the surgery has been done. So a long cricopharyngeotomy helps with good tonicity. We need to have an adequate stoma size. The top needs to be well placed so that we can place that prosthesis. And you want to try and prevent a recessed stoma, a deep stoma. And one of the ways that you get around that is to transect the sternal head of the ECN muscles. And for optimal patient results, we need a multidisciplinary team. So yes, some of it comes to us, but we need to call on our colleagues in dietetics, occupational therapy for some of those other issues, or refer to our colleagues in GIT for the management of some of the problems, or USENTs to do some of the surgical procedures. And when working with these patients is a lifetime commitment, because once they have the surgery, they are dependent on voice prosthesis and replacements for the duration of their life. And again, if that cancer is caught early enough and you're able to resect all of that, patients can have a good life. And we've got patients coming to us 20 years post-surgery, and we're just doing the replacements. But then some of these later side effects happen. So it is about being there for the patient, listening to what the complaint is to try and figure out what's the cause of this problem and how do we solve it. We have had very many complex cases in the last while, where what we planned just doesn't go according to what we think should happen. And again, that's where as a team we support each other and just look at what are the options that we have for our patients. That's all I have for you for this morning. Some of the helpful websites, just for more information, is the Provox ATOS medical websites. They've got the Provox devices that we currently use here. They've also got some training videos on how you place the prosthesis, how you replace it, some of the troubleshooting ideas. And then the Blomsino website is also quite helpful. We used to have a supplier for that. We don't have one at the moment, but they've also got some nice products that are quite helpful, and then also some helpful webinars, tips, training, and educational material. And, thank you.
Thank you very much, Nasreen.
Any questions?
It was a wonderful presentation, and I also just want to take the opportunity to thank you and your team for the service you guys give our patients and all the help you give us. I mean, I personally work with these patients independently. I'm in a department where we don't have as dynamic a speech therapy service, and it's definitely to the detriment of the patients, and also it takes a huge workload off our shoulders. So thank you very, very much. We do appreciate all the effort you guys put in, and also pre-operatively and perioperatively, not just post-operatively. You guys often counsel the patients better than we do. So thank you.
Because the repeated counseling that helps if they get the initial information from you, just having that information repeated and having that time to process is not helpful. And again, it's helpful having a team that we can refer to when we have problems. So when we see them, it'll fall and come up with a plan. So that helps. Thank you.
Thanks, Nasreen. Fantastic talk. Is there any questions or comments from the gallery? I don't see anything on the chat.
So perhaps just a comment for other units. We know that the kind of device recommendation is about 3 to 4 months, but with our 2 to 3, with our budget constraints, I mean, off record, so everyone knows we're replacing the devices on a kind of a device wear and tear basis.
Yes. Yes. Well, company recommendation is something we replace monthly.
Sure.
We can't afford to do that, so we replace when there's a problem. And generally when the company is when we do the replacement, and we try to push for at least 3 to 4 months of device up. That's what we can currently afford to do without that. We have to see what happens going forward. Is going to be price increase that's coming. So we have to look at what our alternatives are. Non-indwelling devices currently are cheaper than the indwelling devices, so that might be something we do going forward. But those are things that we'll have to discuss and see how we manage with the non-indwelling comes with its own challenges of those pieces falling out. Some patients aren't comfortable placing them back in. So it comes with its own challenges.
I've always been intrigued by the monthly device experience, because I don't know, just anecdotally, the more you fiddle with these things, I find the more problematic they become. So, just with the friction and the regular exchange, I was wondering whether you're not creating yourself more problems and waiting for the device to declare itself. So.
Yeah. No, so we do, with our patients, we wait for them to tell us when there's a problem. I've got one gentleman that switches between 2 devices, and that has actually helped his device. Like we see him once a year, patient $2 for a year. So the different things, and some patients are trying their own things. The aloe is one of the things that patients are trying. So, or not. So drinking aloe juice, taking the aloe gel and using the aloe gel to place in the prosthesis. So the same way as how we use the berimocronazole, the nystatin, doing the same thing, placing it inside. Eating the pieces of aloe. So there's lots of patients that do with aloe. But it's maybe something we need to investigate and figure out. If it is something that works and is more cost effective, we've got aloe here. So maybe something else to look at.
Thanks, Libby. Any other comments or questions from the gallery? If not, thank you again, Nasreen, for the fantastic talk and then for giving us your time this morning. So we'll end the meeting this morning and we'll see you on Friday again for our next meeting. Thank you.